Good afternoon and welcome to Sing Life again. My name is KK Yo from the National Heart Centre Singapore. Chairing this session with me is Dr. Eric Eckhout from Switzerland. We're going to have a live case transmission from Brussels on a mitral M-TEER case. And maybe I'll just have a quick moment to introduce our panelists. With us today would be Dr. Choi Ling, our senior cardiac surgeon, Dr. Angus Tree from Hong Kong, Dr. Deepak Davidson, Dr. Yu Si Hui, Dr. Takashi Matsumoto, Dr. Krisida Amimuk, Dr. Amin, Dr. KW Park, Dr. Santoso, and we have Dr. Jonathan Fang here who's going to moderate on the chat as well. So the session will include, will be from the Brussels in Belgium. And then maybe with that, let's see whether they are ready for the transmission. Dr. Lochy?
Yes, we hear you.
And Dr.
We hear you
Adel?
perfect.
Oh, fantastic. Okay, why don't you take us through your case?
Okay, you see my slides?
Yes, we do.
Okay, perfectly. So I'm Stijn, one of the interventional cardiologists here of the Mitraclip team. I'm here with Adel Aminian to my left side, Steven Droogmans and Edgar Prihadi on the echo, nurses Louisa, Anke and Kim, and then anesthesiology, Dr. Beckers on my left side. And also industry support from Abbott Linda. So let's go to the slide. Next slide, please. The case is a 87-year-old female, medical history, paroxysmal AF, atrial hypertension, hypercholesterolemia. Recently, she was hospitalized for acute heart failure, decompensated heart failure, and she had been suffering from crescendo dyspnea since about 2 months. Next slide. So she had an imaging workup in the referring hospital, which showed, so the echo is severe MR, primary MR because of flail P2 because of cardiac rupture, and secondary severe primal mitral regurg. So the ERO is very severe, 0, almost 1. Regurgitant volume about 150 milliliter in this pre-procedure workup, and a mean gradient of 3, normal function of both left and right ventricle, and no significant coronary artery disease on the angiogram that was performed. So next slide. Heart team discussion was done. Because of age and frailty, surgery was declined, and we decided to move forward to a M-TEER procedure with the 4th generation, the G4 Mitraclip device, which I think is all is well known to you all. Which now comes in four different forms, 4 different sizes. Now move to the echo images.
So here you can appreciate the images we are doing live during the procedure. On the 4 chambers you can appreciate the flail P2 with a partially small coronal rupture and with a concordantly severe mitral regurgitation on mainly P2. Here you have the bicommissional view. You can appreciate already that the lesion will be more central-medial with the corresponding jet. And on X-plane view, you can see that nicely against the aorta, there's a severe MR on the level of E2. So during the anesthesia right now, we calculate, here you have the mean gradient of 2 milliliters of mercury, with the systolic blunting of the S-wave at the pulmonary valve. And on 3D, you can also appreciate the P2 prolapse, mainly central and a small P3 component. When we calculate the severity of the mitral regurgitation, we calculate an effective regurgitant orifice of 0.6 and a regurgitant volume of 109 under anesthesia. And here you can see the anterior directed jet on 3D because of the posterior prolapse. We also saw a small indentation you can appreciate on the left, on the LV to LA view in the anterior part of the leaflet. So that is something we need to take into account, I think, during this procedure. On transgastric image, you can see the mitral valve opens quite well with the flail component centromedial, where the biggest jet is, and probably, hopefully not that pronounced on the level of the indentation, and with a mitral valve area of 4.2 square centimeters. The flail gap is about 4 millimeters, and the width a big centimeter, and the length of the posterior leaflet is 1.2 centimeters. So for the transeptal puncture, the maximum height we could obtain was about 3.84 centimeters. And here you can see that we are already navigating with the wire towards the septum, the pulmonary vein, and then transmits it with the guiding catheter, and positioned already the guide on the left atrium. And here you can see that the Mitraclip is pushed through the guide and navigated towards the mitral valve. So this is the position we are at this moment.
So, okay, Stephen. So this is it for the description.
Well, thanks very much. Very nice echo images, and really a case that no one would argue needs something to be done. Remind us, how old is the patient, and was surgery an option? 87.
No, surgery was
I
no
guess.
87, quite frail. I agree. This is you have Eric there. It's a bit of what we say in the, I would say, Swiss mountains, black steep case, black piste case. So we have the indentation in the AML. We have the quite big flail leaflet. So it is certainly not an easy case, but it is a case of a lady that needs to be treated. So another thing that we had some already, let's say, quite some difficulties in the workup before we went live. We were suffering from problems for the transeptal puncturing to get enough height. As you see, we have now about 3.8, which is not perfect. As you see, we don't have enormous height, but we have to work with this. A second thing, and that maybe can be discussed also in the panel, is that because we think we cannot go in the indentation, we choose to go for one clip and to go for the XTW here, despite that the valve is not so big. But that's what a bit our strategy, to try to go for one clip because of the indentation, which we will try to stay away from this. So any opinion from your side at this point?
Good afternoon, also Steven, Stijn and Adel. We see very nice images indeed. We have a big panel here, almost a football team, I would say. So we'll ask a few people to make some comments because you're really, I think it's good that you were able to do the transeptal already. So and you explained a little bit the difficulties, so we can discuss before you start to manipulate the clip. Are there any questions, comments from the panelists, from the audience? Yep.
Hi, Siwi. I'm an imager, probably the only one on the panel. Very nice imaging. It is a small LV. And you mentioned a little bit about the anterior leaflet being a indentation. I don't get a good feeling of that, because in the transgastric view, your anterior leaflet does have continuity. There is no gap in there. So I'm not sure whether the indentation of the anterior may be just because of the three-dimensional echoes when there is a dropout.
It's possible.
Yeah. So I don't think there's a major issues with the anterior leaflet. To me, just important to also highlight the posterior leaflet. When you do a 3D on-fast, there's a little bit of a nodularities. And that reminds me whether there is any potential risk of what we call calcium on the posterior leaflet. But on the P2, you've shown very nicely the mobile part of the P2 does look adequate length. So yes. I have no concern with a P2 giving a XT long clip. Yep.
We had, remind me, 12 millimeters, I think. I looked to my echo people. We had 12 millimeters of length PML at the target zone.
Maybe Steven can comment on the remarks from our echo colleague.
Yeah, we completely agree already. In the 3D, you have the impression indeed, but if you look very carefully on this image, you can see the small indentation goes not through the annulus, so it's not a real cleft. But it's something we want just to show in this case. But we agree, but probably will not be a problem. Let's hope so.
And and the other thing I want to highlight is really the height problems we're a bit suffering with. We did already some advanced maneuvers to gain height, but this is something we are a bit suffering with at this moment.
Thanks. I had asked about the age of the patient and also the option of surgery. Maybe I'll just ask Mr. Chua, our senior cardiac surgeon, what are your thoughts on this valve? I mean, do you think this is a repairable and also when would you refer a patient for clip therapy or TEER?
Well, I think 87, I'm glad you're doing the case and not me. My oldest patient is 87, and after surgery, he actually went back to Canada to fish. So it depends on, what is 87. But I'm quite glad that this is done. I think this particular patient, the presentation is likely going to be acute. It's a fibroelastic deficiency, not much leaflet, and the leaflets are likely going to be quite fragile at this particular age. And I think your problem with not getting enough height is probably because the presentation is quite acute, so atrium's not big. So that's why you have issues with that.
Yes.
So I think for you, it's difficult. For us, it's also difficult because the left atrium is small and the tissues are likely going to be quite fragile. So even though it's a P2, but a P2 fibroelastic deficiency is actually can be quite difficult to repair in a whole patient.
Yes.
Thanks, Mr. Chua. I guess you guys must be waiting to start, but I think there's just one more question that I'd like to ask everybody on this panel. Many of us here are operators or imagers or surgeons, but in this case, I know you have selected your clip already. Can I ask what would the panel here choose? And maybe you have seen the images, you have heard the discussion. Can I just go down the panel here, starting from KW? KW, you have 4 choices. Which one would you choose?
Yeah, I think I agree with XTW in this case. The jet seems broad enough, and if you can get a good grasp with just one clip, then this might be just finished with just one clip. So I think I agree with XTW, and then we can see what happens after the first grab.
Dr. Amin?
Yeah, I think that's, I agree with that. But my only concern is that sometimes when you put one clip, the initial results may look good, but sometimes you may need another one to stabilize. So we always get cases like that. Put one clip, immediate result is good, but then, you may need another clip to stabilize. I'm not sure whether that will also, we'll see after the first clip whether that is necessary.
Thanks, Adami. Chris?
I do agree with XTW because the leaflet is long enough and the fail width is quite wide. I would choose XTW.
Okay, thanks.
But if I use Mitraclip, I select XTW, but this is not a sponsored session, right?
This is not the what?
Not the sponsored session.
No, it's not a
right?
sponsored session.
So if I'm wondering, it's the P10. Pascal P10 works in such case because P10 is a little bit larger than XTW clip, but the reduction of area is less than XTW, I think.
That's a good point. I think Pascal is, in Southeast Asia, is probably going to come soon, but we don't have it yet. So, but it's a good point. I'm glad that Japan has it. I know Hong Kong and some other countries would have it, but not all parts of Asia has it yet. You don't have it yet? Okay, sorry, Angus.
In May.
May, okay. Si Hui, what would you choose? Oh, no, sorry, Prof. Santoso?
Yes, I agree with all the comments, and I'm optimistic that with just one XTW, we can fix the lesions because this looks ideal. Posterior leaflet is very long enough, and also there is no calcification. The lesion is also central.
Yeah, in our lab, we listen to Professor Yu. Yes, so Professor Yu, what about you? What would you tell us to do?
Well, I think all agrees that I would agree with the XTW. I will go for only single, try to optimize as much as possible. The mitral valve area is only 4.2. I think we don't have room for another clip unless you're very close to each other.
I agree.
Yeah. I agree. Angus?
Yes, XTW because the length is enough and there's a little bit a height problem. We just want to minimize the manipulation as much as possible.
Okay, and John, you have a choice.
So I train in the US. In these cases, we want to keep it simple. Would also be XTW, although there's a shift in practice to use more in the Pascal P20 because of the space. It puts less tension in these kinds of leaflet, especially you have nodular, you have worry of maybe a cleft of node. There could be some chance you put too much tension with the XTW and subsequently you have late SLDA.
Thanks. I'm going to ask, I think Eric has a comment about Pascal.
Yeah, I'll try to be politically correct. We have some experience with Pascal, and will it be, a nice device in tricuspid sphere because it looks less tricky to work in this environment? I'm a bit less convinced, certainly in degenerative MI, but I think that the choice of the device seems adequate. Yeah.
Okay.
So I think, Stijn, we have been talking a lot. I think, and Adel and Steven, we let you go ahead and maybe explain to the audience what are the next steps of the procedure.
So we already checked this a bit, but we will repeat this. So I think now we will look at if we are the perpendicularity at this point. So show me the 3D image again.
So this is our regular workup. So we do a 3D above the valve to check for the perpendicularity, and we can also see if you're too lateral, too medial. I put already, as Stijn has said already, because of the height, we had to do a lot of extra manipulation. So we have put a lot of tension on the system. So we must be very careful when we go below the valve.
It looks like we need a bit of clock here, huh?
Yeah, so probably a little bit more lateral than what we think, but probably I will remove a little bit the. And then we keep on the angio, we try to keep the same orientation. When we go below the valve, we try to keep the same orientation.
Clambiture M.
Yeah, I give some M more. Okay, but I really put a lot of tension on the M knob, so...
I think it's not bad. Maybe a bit more of clock.
Yes.
So, I do slow movements because there's enormous tension on the system.
So the thing here is really to keep this orientation when we go below the valve. So we don't have to go too low in the ventricle, of course, because there are the corridors and things like that. So we will close the clip and go just below the valve, try to be as central as possible, keep the orientation.
What do we think of this?
I think it looks good. This is usually when I, ask, CP, you like it?
Looks right place. I wonder, I'm a bit parallax. Is it a bit of, need a bit of clock?
Yeah. I'm wondering if we need more, but I'm not too convinced.
One of the,
but then it's really...
one of the things which... Sorry, I should stop interrupting you, Stijn. Go ahead.
No. I'm not sure we need much more clock. It looks quite good here to me. I look to the other team members.
Yeah, but the challenge will be to keep this orientation when we go below the valve, huh? So we'll see, okay? So
often when we go in, we lose a bit of the perpendicularity.
So it looks nice. We are quite central medial, that's what we
You see nicely the two arms in the one view and the...
So for us it's okay, I mean, we don't have a lot of room and we're already touching the valve already, so...
So I would be ready to go in if you agree.
Yeah, the explained is good actually. It shows very nicely that
so
without any manipulations
So I will try to go in slowly, not to move this, not to lose this.
So we close the valve first.
But it's not, I don't think it's necessary to close.
A little bit
Are you
more.
closing a little bit the arms or not?
Yeah. We have closed the arm already.
I did.
Okay, now you are just below, so we didn't lose the orientation, which is a good sign. We are still central, it's nice. So now slowly Stijn is coming up and try to catch the leaflet. I try to help him with the orientation of the catheter, so we have already both leaflet. So at that point what we do usually is that we are central, it's nice. We do again a 3D when we are just at the level of the valve, the leaflet are in, so now we do the fine tuning. It's our
okay, give me the 3D image again.
Classical technique here. So we love to have this 3D just before doing the grasp. And hopefully we haven't lost a lot of orientation.
Slightly maybe, also maybe again correct a bit in the counterclock side now.
You know, that's fine tuning that we do every time. And even if you are just at the level of the valve, we go slowly down.
A few millimeters again.
And then we turn. And sometimes it's really, we gain a lot in terms of orientation.
This looks better now. We go back to the 2D.
Yeah, I really like the way you make those fine adjustments because in the setting of a long clip arm device, you know, small, you know, lack of perpendicularity can have you know, quite a lot of important consequences. So this is really
with the XTW. Yeah.
I think we might need a bit more posterior. I look to the team members.
Okay, so that's fine tuning. I go more posterior. We have the anterior nicely at the hinge point. Now I've moved posterior. We haven't lost the orientation on the angio. It's nice.
I think it's quite nice here. I would be tended to try a grasp at this point. I will come a bit up and close also a bit more. And come a bit more up. I think this is a good position.
So now we are not using adenosine here, so we will try to drop the
You have a
grippers
lot of posterior,
at the right
good, yeah.
at the right point. So we have, I think, enough of both valves. The orientation is good. Yeah, we have it. So it's close at 60, and then we close completely, and now we can see already that we have a nice catching of the posterior and anterior is in.
How is the blood pressure?
We can ask our.
We'll say we'll tell you in a few seconds.
Okay, I think I'm nicely closed. Let's see what the result is at this point.
Yeah, have a good catch.
I think we see a nice reduction already on the three-chamber view on the right side. On the bicommercial on the left image, we can appreciate the small jet medial of the clip.
You know, you have remarkable, your imaging is very nice. You managed to show the leaflet capture. But this is usually where the headache comes. That's usually where all of us discuss, you know, do we move the clip? Do we not move the clip? Is this good enough? Is this not good enough? Can I ask that you check the gradient and maybe do the rest of the valve interrogation?
If you agree, we will do now the full imaging workup now to see the insertion of the leaflets, the gradient.
Just my comment I made before, Stijn, did the blood pressure increase after the clipping?
Did you see an effect on blood pressure? How much? So about 20 millimeters of mercury rise in systolic blood pressure. So a very nice response also hemodynamically.
And I saw that the V wave was quite low, 25 before.
Yeah, but I'm planning to show this in a minute if we decide not to move it anymore.
So we have a mean gradient of 5, and which is totally acceptable because the reduction is more important than the gradient that you create. This was also shown in the TVT registry when the best outcome was in the patient when you had a residual 1+, not more, and even a gradient of 5 was not
totally acceptable.
It was not a problem, so it definitely we will accept. And this is definitely a one-clip case for sure, because for everything we have said before. But I think it looks easy the way how we grasp it, but actually we have done a lot of manipulation before to be sure that the axis was good, that we're perpendicular, and really that's the kind of case when you cannot do like a 4 or 5 grasp because the valve are not.
It's not tolerating this.
Yeah, it's not a good quality.
Stephen, can you document also? Can you talk a bit about the pulmonary vein flow? Is also something that we check also regularly in routine.
Yeah, but we already seen and it's published a few times that the systolic flow on the pulmonary vein gives a good idea about the immediate result when we compare pre to post. If you remember the pre-image, the S wave was blunted, and we can see that the S peak now is a little bit higher than the diastolic wave, so this is already a good hemodynamical sign we can appreciate on echo.
Yeah.
So while you do the rest of the interrogation, you know, maybe I'll just ask the panel, what do you all think? Should we shift? Should we let go a bit of the leaflet? Are you all happy with this? Maybe just in reverse order. I mean, Mr. Chua, our cardiac surgeon, any comments?
I think gradient of 5 for this one, because it's a small valve, I think it's perfectly fine. The regurgitation, well, I think it's a very significant reduction, yeah. But I'm not sure whether we should regrasp again. I have no experience with that.
Also, a good sign also is that we don't see a lot of smoke in the left atrial cavity, because sometimes when
I
you
think
have
there
really
is
like
already residual check on both sides of the clip, so I think the location-wise should be good.
Yeah.
But I would like to interrogate a little bit more, and especially look at the posterior leaflet, because I'm not very sure whether the posterior leaflet is a little bit mobile, the residual posterior leaflet. So I would tend to look a little bit more deep into the posterior leaflet, make sure it's really good before we release.
Before we go to this, I would, if you agree, I would just show the hemodynamics of the V-wave. We just took this measurement.
But it's a nice comment that we check a lot that the insertion of leaflets are good. So that's a very good point from the panel. But if you look at all the different, I would say, gatekeeper, so we have the orientation is good, okay? We are central. The clip is not off axis.
The gradient is acceptable.
The gradient is acceptable.
The MR reduction is one or
exactly.
no more than 1 plus.
Normally, if you don't have enough leaflet, you end up with some flow around the device or something like that. But this is already a good sign that the grasp is correct.
And like somebody in the panel also says, we have nicely the both jets to the side, but not the swirling jet that's coming from the clip.
Very important what Stijn said, because when you have that, it means that the clip is usually off axis, so you need to reposition the clip. It's something that we look for a lot. Yeah.
So you saw the hemodynamics. Maybe now Stephen can comment a bit about the insertion of the leaflets, if you agree.
Yeah, we have here the three-chamber view, and we measured the residual posterior length of the posterior. It's also sometimes quite helpful to have an idea how much is in the posterior. It's about 4 millimeters. Remember that the length was 12.5, so it means about 8, perhaps 9 millimeters is expected to be in the posterior part of the clip.
Takashi, any comments?
I'm very happy to this fast grip. Of course, the baseline mitral valve always was 4.2, and mean gradient now it's 5. So definitely this is one clip case, and now we can see the small jet in both sides of clip. So it means there's no chance to shift the one medial or lateral side. I take this fast grip deployment.
Okay. So it looks like Dr. Takashi would take this. Anyone would not take this. Dr. Amin, you?
I think it's a good result. I think the gradient of 5 is a one-clip case. You can put so I think we are more comfortable about 3 or 4, but this is already 5. So you have to make sure that you've got enough leaflet in both posterior and anterior to make sure, look at all the views and be very sure, because this is probably a one-clip case.
This is a very good point that we check for a lot of views. You have to do the 3D. Sometimes we do the transgastric.
I just wanted to say that maybe if possible, can we show the transgastric also, which we also do quite often, and also give
Actually, we have no doubt about the ground, but it's nice to show that sometimes when we are in doubt, sometimes the transgastric can help to see that you have very nice tissue breach. So it's good to have a lot of views to confirm that, because when the clip is released, it's finished. If you have a detachment, that it's really it's not can be a nightmare. So we see very nicely the bridge. It's very central. The orientation is good. So it's good to check. We have time to check. It's a smooth procedure. You don't have to rush. It's not like TAVR. So
okay.
I think that Stijn and Steven and Adel, I think that I would say there's nobody here in the panel, neither in the room, that is having objection to the result. If you put this whole thing into perspective, this lady is 87. She's not going to run a marathon tomorrow. You will relieve her symptoms, certainly. And when, as you mentioned, when you see the difficulty you have with the transeptal puncture, with the height of the device, and an acceptable gradient that will probably go down to 4 once you release the clip, it's probably very wise to stop there. Yeah. Any other comments, or do you wish to proceed with the final movements, and maybe explain to the audience also who doesn't know how you do the final release of the device or the final things you do before?
Yeah, sure.
So everybody is agreeing, and also in the panel, to release now. So I release the cap. We are increasing the
flush.
Wait one moment. Je kunt u desteriliseren. Is okay?
So we have to remove the lock line and the gripper. So we do that in 2 steps. Stijn is now first moving the lock line.
Can you ask the people from the regie in you to inverse to make the your hands big and the echo image small? Can you invert the image? So we don't need to see the big echo. We need to see the yes.
The hands of Stijn. Okay.
That's perfect. Yeah.
So that's a little bit the tricky part.
Delicate always. So we have.
You have to avoid knots here, for example. You have to be sure that they are really free. That the two components are free.
And you hold this one that it doesn't come back.
Once you remove,
Maybe I'm a little bit superstitious, Stijn and Adel, but I always keep my hands on the device while, as the primary operator, while the second is working.
Yeah, you're right, Eric.
Okay.
I just take the advantage to say that I was a former fellow of Eric Eckhout, just to. So if I'm there, it's because of him.
So lock line is out at this point. I always have a look then. This looks stable.
A little bit overstraddled, but it's okay. That's not.
Yeah. Okay. So now I go to the neutral position. Neutral position. I take out the pin. And now I expose the groove. Don't see it quite well. Okay, I exposed it, and now 8 turns. And okay, and I bring it back.
And now the grippers also.
And also the grippers.
And now the clip is free. Then we come back.
Can we see the X-ray instead of the angel?
Yeah, sure.
Wait just a moment and show the. That's what we want to see. Yeah, and show the X-ray in large.
It doesn't come up.
Wait. You see the X-ray?
Yeah, but yeah, that's it. Yeah. Perfect. Excellent.
Wait.
More than this?
You can go ahead. We see it. Yeah.
You agree? Okay.
X-ray.
Okay. Now we try to take away the pin. Maybe the straddling. We can come back with the. Yeah. Voilà.
So in case we have to put a second clip, we try to keep of course, the catheter inside the left atrial cavity, but probably here it's a 1-clip case.
Take the M off.
So I take the M off, and then we come back with the full system. Yeah, we have to remove because we have put a lot of M on the system.
Can you follow the pin? Follow the pin. Yeah.
Okay, just one more.
Watch out! Don't lose.
Okay. Just 1 second.
Watch out.
Can you remove the slack? Can you remove the slack a little bit?
Posterior. Was mere posterior because you're close to the. Okay.
But there's a lot of there's a lot of M here.
That's okay. Now take it out.
That's a lot of M. Just 1 second.
Here.
Are you going to keep the guide in the left atrium or?
Yeah,
we try, but we have put a lot of tension on the system. So anyway,
yeah. So for the audience, when we have these height issues, there's usually a lot of maneuvers, a lot of A and P knobs, and it can really create a lot of strain in the system. So the team is reversing some of the steps so that we can see the jump. Yeah, so that's a bit scary sometimes.
Yeah, because there was so many tension on the system, that's why we have to be careful. Every step we have to be careful.
I feel you're on the right side. Yeah.
We're still in. But can you have a look now at the final result? The V wave is still abolished.
So it's very stable, as you can see.
Yeah, but you know these kind of valves usually will scare me a little bit because the leaflet is the posterior leaflet is, still has some degree of prolapse, and I'm glad that you chose a long clip, and with the normalish EF sometimes it can be a problem.
So we'll check the gradient again. Like Eric says, so often when you release, this gradient still comes down a bit.
What is the heart rate? 60. Okay.
It's 66 at this point. Grade still 5, so it has not changed. But I agree with the panel. I think in an 87-year-old lady, it's a perfectly acceptable result with a MR reduction to 1 or 1+. I think it's a very good result, honestly.
Yeah, I think this is really a spectacular result. 87-year-old, large flail gap, flail segment. I think this is can't ask for better than this, and you did it very smoothly. I think the audience here didn't get to see you. How do I put it? Navigate the height issues, but once you're there, you were able to demonstrate that slow and steady, careful interrogation of the valve, and leaflet insertion being verified is a very reassuring thing.
Nice tissue breach here also on the 3D.
Yeah, very nice images on 3D. Is there anything else that we should look at? Maybe I'll just ask Chris or KW or Sihui or Dr. Santoso whether you want to see anything else on echo before you say let's call it a day with this particular case.
Not on echo, but the patient has paroxysmal atrial fibrillation and history of heart failure. Is there any plan for this in the future? Because I think maintenance of atrial function is important for this.
I agree, I completely agree. But I think that the AF might be a bit induced also by the MR, which is now abolished. This is an 87-year-old. I would try to be pragmatic. If this patient now, let's say, stabilized on the symptomatic level, I would try to limit the number of invasive procedures in this lady. Yeah?
I think one thing probably you will have to check, Stijn, because there was a lot of tension during the work, is to look at the interatrial septum to see if you have no damage.
Yes. Okay.
So
can we show the septum? Good remark, Eric. Can we have a look at the septum? We will show it. Sorry, we have still the guide through now.
The guide is still through, but I can remove it.
We can, if everybody agrees, we come to the right side.
I'll come to the right side now. Okay. So I put an M on the system to straighten the system, and I take it back.
The minus, maximum minus.
Yeah, it's minus, a lot of minus.
Okay, perfect. So I don't think that we see it as we always see the small left to right shunt, but this is not a very big shunt in my personal opinion, and often it closes spontaneously after some week to months.
You can see here that the height of the puncture was really low actually, because every time we wanted to move posterior, the sheet was falling down, so we had to make a compromise. And also it was a very thin septum, and even without the needle, it was crossing already with the catheter. So yeah.
So this is actually very illustrative that the height makes a difference, and where you puncture in the septum. So can I ask, did you use diathermy-based technology, or do you just use BRK or?
No, but here's a very thin septum, so we use BRK. But if you have thick septum, and of course we use adjunctive devices, but here it was a very thin septum, and so yeah, it was not an issue about. It was more the anatomy of the patient, and when we're going down on the bicable view, we could never get a high and posterior puncture, so we had to make a choice, and we decided to move more posterior, and then every time we have lost a lot of height. So and then the most important thing is that we had to do a lot of manipulation with the anterior steering of the device, and so at the end you put a lot of tension on the system. Hopefully, when that can have a repercussion when you try to go below the valve. Then you see that there's a lot of tension on the system, and the clip is moving a lot. Hopefully, it was not the case here. So we did and also we have seen that Stijn didn't go really far into the LV, which is also very important.
And yeah, we certainly with the big trick clip, we always try to limit the number of movements and not to lose perpendicularity at this point.
And regarding the choice of the clip here, one of the main important point is that it's a central jet.
Yes.
If the more you go to the commissure, the more we go for a small clip.
XTW.
Yeah, we try to have NT or NTW because then it can be dangerous. If you're a little bit off axis, then you can get entangled in the corner and things like that. So here it was central. I think it was a good choice. And also, I wanted to discuss with the panel. In Belgium, we have seen a shift from we do more and more DMR and less FMR because of the all the improvement in the heart failure treatment.
We have
And I would say like 5 years ago it was like
50-50.
Even more. I mean, it was 60% of functional and less DMR, and now we see
it's less than
a big trend.
We do certainly less than 25% of primary now, less than 25 of functional at this point, and really the most of our caseload at this point has become primary because of improved heart failure therapy.
Yeah, I think that's a really good point. We face the same experience here.
Yes.
Look, you guys have done an amazing job showing us a very successful Mitraclip procedure for a very challenging anatomy. So I'd like to thank you. I think we are very happy to let you guys off a bit early while the panel will continue to discuss some of the technical aspects. So thank you, Dr. Stijn and Dr. Adel and Dr. Stephen. Very well done from Brussels. Thank you.
Yeah, thank you. In name of the team, I would like to thank you for having us. It was a pleasure.